Well, good morning, everyone. Thank you for joining us for this first of what we hope will be a long-running series of Zoom meetings on what we're calling right now the COVID-19 Vaccine Alliance. I'm just going to quickly go over what you can see on the slide right now, which is our mission in collaboration with the New Hampshire Department of Public Health Services. We're going to convene stakeholders in the Granite State to help promote vaccine confidence, support accurate and consistent vaccine messaging, and hope foster coordination of the vaccines allocation process. Our goals are to promote public buy-in for the vaccines to help increase immunization rates, to, and this is the key one, really act as a multiplier force to support the Bureau of Infectious Disease Control immunization programs efforts in both their vaccine communication and their allocation plans. And three, to counter misinformation on the COVID vaccines. And then our fourth, when we enter into the public distribution, more public distributions, phases 2 through 4 of the vaccine immunization process, we're going to hopefully foster New Hampshire's vaccine registry, which is called the Immunization Information System. Thank you for joining us today. We anticipate that the stakeholders will change over time. The focus of this particular meeting is really on the distribution or phase 1A. And this is a bit of an organizational meeting to kind of get us started. And Brian, I'd like to turn the microphone over to Steve Anand, if I could, for a few remarks, as both the Hospital Association and the Business and Industry Association are partners in helping bring this together. We also have a number of sponsors that we'll announce in our meetings next year. But we anticipate that we have raised about $100,000 to date to help us support these various efforts going forward. When we appreciate all the contributions that have come in, very generous, and we'll talk more about those as we kind of move forward in the campaign. But Steve, would you like a few brief remarks, please?
Sure. Thanks, Jim, and thanks for convening this group, and appreciate everybody's participation. As Jim really noted, I mean, this is really an opportunity to multiply the message that we're all more powerful when we're working together and communicating in that way, sort of the and one, if you will, and really building upon the example of what we did over the summer in terms of the Mask Up NA campaign, which I think really was a great effort and really brought together lots of different stakeholders, well beyond just healthcare, business, and chambers and others, to really amplify the public health messaging that Dr. Chan and his colleagues have been sharing for months, and that we need to continue to share. But now that we're getting to the point where we have a vaccine, we really have an important opportunity to continue to amplify those messages. And I think again, we're working in partnership with public health to get those messages out, to help people understand the value of the vaccine, safety, and the efficacy. Those are important questions that people are going to have, and we need to be able to respond and answer all of those. So anyway, we're really excited about the opportunity and the effort, and we look forward to working with everyone to help move these messages out and to help move us hopefully closer to the end of this pandemic than we've been. So thank you, Jim.
Thanks, Steve. We very much appreciate it. We are very fortunate today to have Dr. Benjamin Chan join us. As you all know, Dr. Chan has been a face of public health and many of the briefings that he's done in media and with Governor Sununu. And I asked him just to kind of come in and join us briefly in this first time for this meeting. So Dr. Chan, thank you very much for coming and joining us this morning.
Great. Good afternoon, everybody. And thank you, Jim, and members of the New Hampshire Medical Society for organizing this call. I am one of a much larger team in public health that is looking at trying to roll out these two new COVID-19 vaccines. And so I'm joined today by T.W. Hull and I believe Colleen Haggerty, who are overseeing the operations of getting this vaccine out. And they're really a couple of our subject matter experts on the finer details of some of these vaccines and the rollout of these vaccines. So I'm going to let them introduce themselves perhaps in a couple of minutes, but I just wanted to say thank you to the New Hampshire Medical Society and for all of you for joining. You know, we continue to see very high levels of community transmission of COVID-19 in New Hampshire. And New Hampshire is not unique to this, and all of our surrounding states are seeing very high numbers. And we continue to rely on the community mitigation measures, the social distancing, the face mask use, the avoidance of crowds and gatherings as the primary way to stop this pandemic. But we know that those efforts are limited. You know, we're 10 months now into this pandemic. It becomes more and more difficult to implement those types of strategies to prevent spread of this virus. And it's even more challenging when you take into account the fact that this virus spreads very easily person to person, and even when somebody is asymptomatic. You know, the CDC has estimated that 40 to 50% of people with COVID-19 are asymptomatic at the time of their infection and able to transmit it to other people. That poses many challenges to stopping the spread of this virus, which we're witnessing in real time as transmission spreads across our communities, between states, across our nation, globally. So this pandemic very much is active in New Hampshire and continues to be active globally. And the vaccine is going to be the tool, I think, that a lot of us expect to have to bring this pandemic under control. Simply having the vaccine available does us no good if people don't take the vaccine. And there's been a lot of vaccine hesitancy that's been built up over the months. There are some, surveys that have shown early on that 50% of people were hesitant to receive the vaccine. And those numbers have certainly improved, but, we're still looking at potentially 30–40% of the population that is reluctant or hesitant to take this vaccine for a variety of reasons. And so it's incumbent on all of us to put out the correct, accurate message around this vaccine. This vaccine is not only highly effective, and that's the good news, right? The FDA set a very low bar for approving any COVID-19 vaccine. The FDA bar for approval of a effective vaccine was set at 50% efficacy. We now have two vaccines, the Pfizer-BioNTech and the Moderna vaccines, both of which are about 95% effective at preventing COVID-19. So we have these two highly immunogenic, effective vaccines, which are going to increasingly become important for controlling spread of this virus. And we know that the vaccines are also safe. Yes, people can and will experience side effects after the vaccine. Both localized symptoms and side effects, as well as systemic side effects like headache, fatigue, maybe even fevers, chills, muscle aches, muscle pains. But that's a symptom of the vaccine working. And so I think we need to get the right message out there that we believe these vaccines are safe. We know that these vaccines are highly effective. And I think going forward, there's going to be increasing need to be promoting and not just making these vaccines available, but strongly recommending and encouraging and advising people to get the vaccines, because this is how, this is one of the prime ways that we have to end this pandemic. And we're not going to be there right away. The vaccine rollout is going to happen over months. It's going to be a process. And we need people to be patient. Right now, we're targeting the limited supply that we have to the frontline health workers and long-term care facility staff and residents. But in the coming weeks, as vaccine becomes more available, we are actively working towards rolling these vaccines out into the public setting to begin vaccinating people in the ambulatory setting. So with that, let me stop. And I don't know if TW and Colleen want to introduce themselves. I know everybody's coming from another meeting, so I think they were a little delayed in getting on. But it would be good if they could introduce themselves, because they are absolutely critical to making this vaccine rollout effective, and for the success that we've had so far in getting it out relatively seamlessly. Thank you.
Thanks so much, Dr. Chan, and thanks, Jim Potter, for facilitating this meeting and inviting both TW and myself. So my name is Colleen Haggerty, the Immunization Section Chief here in the Division of Public Health, co-leading with my colleague here, TW.
So good afternoon, all. Thank you for having us on the call. I apologize on Tuesdays that we have a meeting that ends around 12:05, 12:10. So if we're ever invited to this group, we'll always be just a little bit late. So my apologies for that. I'm the CDC Public Health Advisor for the state of New Hampshire. I'm also a commander in the United States Public Health Service. Please feel free to call me TW. In this role, I'm serving as the Vaccine Operations Chief. And so when I talk about what we're doing, I'm not speaking with the United States Public Health Service or CDC necessarily. I'm speaking on behalf of New Hampshire. So been up here for the last 4 years. You all have an amazing state, and thank you for giving us the chance to speak to you today. What I'd like to do, if it's all right, Jim, is talk about our strategy a little bit in terms of allocation and what we're going to do. I think that's on everyone's mind, probably first and foremost, and then we can start to dive into the weeds of how we've gone about doing fair and equitable distribution and some of the other finer points out of this.
That's terrific, TW. Just let me hold you up. Just for the rest of those participating, this is exactly what we were hoping you would present on. If you have any questions, please type them in the chat box, and it will go to myself, TW, Dr. Chan, and Colleen, and Steve Anand. Type those in there, and we'll relate those questions. We'll answer as many as we can as we're moving forward. So through the course of the descriptions, please chime in with any questions you have through the chat box. TW, I'm sorry for interrupting you. Please go ahead. Thank you.
Sure, absolutely. So, okay, so let's talk about first how vaccine is coming into our state and where it is going, and who are the groups that we're looking at vaccinating is a first part of this. So in 1A, what we're looking at is we're looking at vaccinating almost all of the skilled nursing facilities through what's called the PPP. That's the Pharmacy Partnership Program. That is a direct relationship or contractual agreement between CVS and Walgreens and CDC. And so if you are affiliated with a long-term care facility, whether that be as residents or as staff, you would be looking at getting vaccinated through that organization. There are a few assisted living facilities that chose not to sign up with CVS or Walgreens, and they will be vaccinated through what we call our regional public health networks, which some of you might be familiar with. So we don't have, as you know, local health departments except for 2 in the state. And so the regional public health networks will be vaccinating under direction from the state of New Hampshire for vaccination in some of these areas. They're the mobile part of our response. So if you take the overall response that we have, and if we had a crystal ball and we were looking back at the way that our response ended up, we'd be looking at roughly about 75% of our vaccine going out through private partners, whether that be yourselves as primary care providers, whether that be through urgent cares, whether that be through pharmacies, whether that be through dentists, whether that be through a variety of different ways. We're looking at trying to get this vaccine out. That then entails making sure that everyone's looped in on a communication loop, right, so that we all know who's getting vaccinated, and I'll get into that a little bit later on. But I do recognize that that's an important piece of this. So the other 25% is the public side of the response, if you will, and for that response, we have a setup of 2 different mechanisms to try and create fairness and equity. The first is what are called fixed sites. And those fixed sites are broken out by each regional public health network, so each region of the public health networks, and it is set up in such a way so that it is a fixed location in each one of those areas that we then staff through National Guard initially, and then possibly later on through some other mechanisms, to be able to create a high throughput of vaccination through the efforts of the state. And so if you think about the public side of the response, if we had a workhorse, if you will, or where the majority of the vaccinations are going to occur, it's going to occur through these fixed sites. If you then move to the regional public health network, they're the other side of the public response, and they're really designed around the concept that not everyone's going to be able to drive a car, get there, show up at one of these fixed sites. And so the regional public health networks are the last tool in our toolbox, so to speak, to create equity and fairness, set up, regardless of where we're at in the response and who we're trying to vaccinate, a way for people to get vaccinated with bringing vaccine and vaccinators possibly to them to actually get vaccinated. So those are the mechanisms that we're trying to use, or the tools that we're trying to use. So let me take that down to provider level of what we're trying to do in 1A. So in 1A, we're trying to vaccinate long-term care facility residents and staff. We're trying to vaccinate first responders. So those are fire, EMS, and law enforcement that provide medical details or assistance. And we are also trying to vaccinate healthcare workers. So let me talk about how we're vaccinating healthcare workers. So for whether or not you practice in a hospital setting or an ambulatory care setting or another healthcare setting, you are in the category of this health worker. And in that category of health worker, we are looking at asking you all to striate yourselves versus most risk, moderate risk, or low risk, right? And that all has to do around patient exposure. So that's our ask of the community to do at a local level, whether that be your private practice, whether that be a hospital organization, whether that be fire and EMS. To some degree, we're asking to do this. So again, I'm a nurse by training. I'm going through a nurse practitioner program right now, and so if I'm not out doing clinical work and I'm behind this desk, then I'm not necessarily getting vaccinated right away. We're shooting for the majority of the vaccines to go out to the frontline workers to take care of them. So that's why we're asking for most risk categories for both the hospital and ambulatory care settings and other health worker associations to be vaccinated first as a part of 1A. Then we go down to the moderate risk category of healthcare providers and having them vaccinated as a part of 1A. When we get into the lowest risk category of 1A, that's where our lowest risk health category, that's where we start to get into whether or not you're at that lowest risk category, whether or not you're considered essential personnel. So that's the accountant in the back that never has exposure to a patient or not. If they're essential workers like that, then they're vaccinated as part of the essential workforce later on in the process. So possibly as a part of 1B, right around in there. So that's kind of how those striations work. So now, how do you get vaccinated in this schema of these different areas when you are not affiliated with a hospital and you are not affiliated with a long-term care facility? That's the guidance that we're looking to try and put out this week, and we're working through the back end of this to make sure that it's an organized and customer service focused way of doing this. So the way that we're looking at doing this is through our fixed sites. So at the beginning of the response, right, as a part of 1A, we cannot set up vaccination agreements with each one of you in your private practices in enough time to get you vaccine and get you set up and distributed with vaccines so that you can vaccinate yourselves. Although, to be honest with you, we would love that if that was a possibility, because that would make our lives a lot easier. What we are looking at doing is sending out provider agreements, and we sent those out yesterday, so that you can fill those out and get those ready to vaccinate your patients as a part of 1B. So we're looking at bringing on that capability as a part of 1B and possibly sooner as we go through it. But we recognize that we want to get you vaccine as quickly as possible, and our overall goal for this is to not allow our processes to slow down the distribution of vaccine. So what that means is that if you are not affiliated with a hospital, you are not affiliated with long-term care facility, then we will be sending you out guidance on how to sign up for a fixed site and how to be vaccinated through there. If for some reason you absolutely cannot get to a fixed site, then as our very last methodology, we have as the regional public health networks to go out and provide a mobile clinic where we bring vaccinators and vaccine to you to do that. Now, I'm saying this to all the groups. I just got off a call yesterday with the Chiefs Associations for law enforcement as well as fire and EMS. Please think of that mobile clinic as a last-ditch effort because we have to share that resource throughout our state. And that's our only way to put boots on ground and shots in arms, so to speak, in a mobile setting. So please use that judiciously. If you can get you and your staff to be able to go to a fixed site, I would implore you to do that so that we can make that run smoothly. So a couple of things about the fixed sites. We're running them Tuesdays through Fridays. And again, this information will all come out later on this week. We are looking at setting up a process in which our clinic work schedule starts an hour later each day so that we can account for morning hours and evening hours throughout the week. And then on Saturdays, we go from 8 to 4. So that gives you some versatility in terms of trying to work through different things. The other thing that we would say is that as you are looking at vaccinating yourself and your staff, give yourself a window in case these systemic side effects that are coming out, give yourself a day or two to bridge that gap of people getting vaccinated, right? So if I was running a small clinic by myself and I only had, one other provider and 2 support staff, all 4 of us getting vaccinated, again, the percentage of systemic reactions are very low, but I don't know if I can handle a quarter of us being out of work at one time and still handle our throughput of our clinic. So think through those types of things in terms of when you're scheduling people to get vaccinated. Once you have that in your head of most vaccinated or most risk categories of getting vaccinated and how that works for your clinic, and you've gone through that and you're ready to now sign up, then the next process is to get you into a portal into the state to get that set up so you can get the invitation to vaccinate. A couple of things out of that, or caveats out of that I just want to talk about with you all. Number one, we don't want a situation where people are finally getting to the sites to be vaccinated and it's the first time that they're hearing if they're pregnant, they should really have a conversation with their healthcare provider. So we want to set up a situation in which people are filling out a form online. They're getting immediate feedback with actions saying, hey, if you fall into one of these categories, we would suggest that you have a conversation with your healthcare provider. The healthcare providers, because I know I'm speaking to you guys as healthcare providers too, then would go back to the HON and some of the other areas that we've distributed this information for you to talk about and have a conversation with them about risk versus benefit of being vaccinated or not. So that's kind of how we're setting up that piece. As those requests come in off of that system and they come into the state, then they are received at the state, and what we will do then is take those requests and then figure out by allocation how much we can allocate. So keep in mind, right now we're allocating most risk hospital workers. We're starting off next week with vaccinating most risk ambulatory care workers and first responders. And so based on the calculation that our vaccine allocation strategy branch has done, I don't want to put all first responders and give all first responders all of the slots in a particular fixed site. I need to make sure that we're balanced and we're equitable in terms of those numbers going through. So on the back end, when you submit that information and you say, look, my name's TW, here's all my information, yes, I qualify as a most risk health worker, and I submit that, there'll be a natural lag time between when you submit that and when you hear a response back to us. You'll hear a response back to us by email. If you do not have an email or an email capability, then that will involve a process which we're currently working out right now, so I don't want to misspeak to it, but that will involve us reaching out to contact you to get you scheduled. So that's kind of the process of how it works, how it flows, how we're trying to keep things equitable and push vaccine out in a quick and efficient way while we're still working towards the next stage of the game with getting provider agreements in place so that all of you that want to join us in this vaccination effort have the ability to do that.
Thanks, Colleen. Do you want to add to anything at this time, Colleen?
Good.
Okay, there's a few questions that came up. TW or Colleen, could you talk about the VAM system, because I believe that's what you're using for 1A, and talk a little bit about that process, how people, I'm sure it's coming out in your guidance, but talk a little bit about that process, and then how that's going to be differentiated from more the phase 2 general public.
Absolutely. So let me talk about the way that we're documenting. So we need, depending on where you're getting your vaccine, right? We need to keep a local record for that with your EHRs or your paper records, right? So we want that obviously to be included in your medical documentation. But we also need a system that is statewide so that we can coordinate these different sites and these different areas. So the first part in 1A is utilizing the VAM system to do this. This is an online portal. You go through a website link and you get signed up. We have training here at the state, but it is not the state system. It is a system created by CDC. And forgive me, I'm just going to take a quick drink. I've been talking since 8 a.m. But this is a specific system that we have that's designed to basically communicate in a couple of different patterns what we need to get. So the VAM system is set up so that you can utilize it in two different ways. The first way that you can utilize the VAM system is by just doing data entry. Give us the basic demographics and the vaccine that was administered, boom, in and done. The other way that the VAM system can be utilized is actually for patient scheduling and registering and things like that. And so what it does is it allows providers that are using that system to be able to send out an email invitation and get people to register if they don't have registration software, and get them into the system by doing the demographic entry themselves. So it decreases the provider's load of having to re-enter into a new system all of the demographic data. So that's the VAM system and what we're doing with it. When your information comes into the VAM system, then it goes in two different directions. The first way that it goes is it goes into what we call a data clearinghouse. So data clearinghouses are designed or set up so that there's limited access to them, and then that information is de-identified and sent up to CDC for information of the aggregate data that's needing to be communicated at a federal level. It's also then going from that data lake and transferring into our immunization information system. So if you have not heard, because of all the things going on, we do actually now, believe it or not, as a state, have an immunization information system, yay us, and it's been rapidly getting deployed. So it's about a year to get that deployed. We've been working super hard to get that done, vetted, and messaged and set up. It's set up now to take care of the back entry portions of this response, to be able to move through and be a data collection, as well as some other functions that we need later on. So that's the backbone of where that data will live in order to do that. Now, those of you who follow along with the political side of opting out or opting in to registries and things like that will have seen that the governor put an executive order together right now that basically states that as a part of this response, if you're receiving a vaccine, that your information will go into the IAS, and you do not have the ability to opt out of that process for COVID vaccine only. So again, it's so that we can get those that primary data back, and we can coordinate what that looks like. This also gives us ability on the public side of the response, because on the public side of the response, we don't have a different EHR. The VAMs and the tool that will replace VAMs later on in the system. So when we get to 1B and beyond, we're looking at taking away VAMs because there's some, well, as you all know, when you don't control a system and it's built for lots of different people, right? As providers, we've all had challenges of trying to document in a system that really wasn't designed well for us. So in order to bridge that gap, we're bringing on a different system to do that as a part of 1B. So I say all that and lay all that groundwork out to say that there's training in VAMs going on right now for those that need to document in it as a part of 1A. Most of you will not need to document in VAMs as a part of this response, because by 1B, when we're standing you up, we will be looking at leveraging either your EHR communicating to our stuff or you documenting in this newer system.
Thanks, TW. Here's another question from a physician in a private practice. He asks, how will we be invited to sign up at the portal to get ourselves and our staff vaccinated? Will the invitation go out, through the department, or is it through partners or through the guidance? How is that done?
Thank you. So this is something that that I'll be honest with you, we debated for a while at the state level to try and figure out the best methodology to do this with. What we ended up settling on was messaging it out through every possible partnership as well as licensing agency and whatnot that we could use. We recognize that that's not going to necessarily hit 100% capture. And so our goal is to send this out through as many different mechanisms as possible for you all to do this, but we're stopping just short of a public notification to the general public to do this. So we're trying to leverage everything else right up to that point to be able to share this guidance and have this information go out.
So a qualifying question came in. Will requesting vaccine for our employees, registering them and scheduling be coordinated within the practice through one person, or is it up to the practice?
Great question. So here's what we've told fire and EMS and law enforcement. This kind of has to be a duplicate effort. So first, we don't want to set up a situation in which your employees are having to share personal health information with you, right? We don't want to set up that situation. So they need to sign up individually, and they need to answer those questions individually so that they can get the information that they need, not feel like they're disclosing something that's private to anyone else, and be able to do that. However, we also need your assistance at a facility level to coordinate a couple of different things. Number one, if I was running a practice, I'd want to make sure that not everyone signs up on the same day in case we have, 12% that have fever the next day or whatnot. But also to communicate really, hey guys, let's have a concerted effort to do most risk right now, right? So let's all kind of pledge to that. Let's all do our best to try and hold to those tiers. And as long as we all hold to those tiers, we can get through the groups in a quick and sufficient method to try and get to the next one.
Thank you very much, TW. A question in specific, will provider agreements be sent to home care and hospice agencies so they can eventually vaccinate their patients?
Absolutely. So I'm gonna state this in a way that's semi-joking, so forgive me for that, but if you have the ability, the license, the capability of vaccinating, we want to have you as a partner in this response as a part of 1B and beyond. We don't want to create barriers to that. We really want to set that up. Now, that being said, it's not as simple as me going over to Dr. Chan and saying, hey, here's some vaccines, have a great time. They have to be stored in a certain place. They have to, so for this, that means that you have to have a refrigerator that's between 2 and 8 degrees. It has to have a continuous data logger that basically monitors that temperature and makes sure that you don't go out of range with this vaccine, right? And that you are submitting data or committing to submit data in a certain way for us to all communicate that. So that's data on making sure that your temperatures are straight, as well as, the actual shots that you're putting in the arm, so to speak. So we want to encourage everyone to do that. We're trying to streamline that process and make it as easy as we can. But there are some minimum requirements to make sure that we do this safely and effectively.
Great, thank you. Next question is, what priority level will pharmacists in retail settings fall? And how do we use pharmacies to sign up to provide the COVID vaccines?
Great, so if we're talking about pharmacists as a part of 1A, then you are healthcare providers. We definitely want you to get vaccinated as part of 1A. We would then ask you to go through, just like we are with all the other groups, and figure out what your risk exposure is and determine yourself where you fit in that category. And I'll give you an example. If I'm a pharmacist that is continually giving vaccines to people and dealing with people in a heavy outpatient setting that are sick all the time, that got coughs and sneezes and sniffles and whatnot, I don't have any barriers in between me and them and everything else, then yeah, you got a decent chance of being exposed, and we want to try and protect you as soon as we can. If I'm a pharmacist that's not giving any direct patient contact, I've got a barrier between me and my patients and whatnot, and good system set up, then you can fall later on in terms of that risk stratification. So again, this is something that we're not trying to be regulatory on. We're asking everyone to put on your Good Samaritan hat, allocate yourself, where you see fit, and go from there. If we're talking about pharmacists vaccinating and vaccinating as a part of this effort, I would encourage any pharmacies to go through and put forth a provider agreement to do that. If you are a part of a chain pharmacy, so let's say that you're a Rite Aid, right? We want to set that up with the Rite Aid chief of the state, whatever that title is, right? And then have provider agreements for each of the Rite Aid chains that are in that setting. So the provider agreement needs to kind of flow from a hierarchy. So for those of you that are doing this as a private practice or whatnot, and you have multiple clinic locations, you want to set yourself up as the organization at the top of this, right? And then you want each of your clinics to be set up as subcategories underneath you to be able to set that up. So it's a clear pathway or a hierarchy so that we know, hey, look, for all of TW's clinics, we go to him, but he has 4 different clinics underneath, and so we need to make sure that vaccine gets to each of these areas. But we've got a hierarchy to go off of to know that they're not 4 separate clinics, but they're really owned by one entity.
Thank you. I have a couple partner questions here. The first one is, if we have a mobile van that can be similar to the mobile clinics that you've talked about, is that something that the Bureau would be interested in trying to collaborate with?
Absolutely. I think the bottom line is we really appreciate all of your creativity. We don't want to stifle that at all. We just need to keep the vaccine safe, right? So any way that all of us can decrease barriers in terms of vaccination, whether they be through disproportionate populations or whatnot, we want you to vaccinate, and we want to encourage that. We need that to be done in such a way, though, that you can keep continuous temperature monitoring and keep that vaccine safe. And so as long as you can do that, you have our support.
Terrific. Next one comes, if retired or part-time physicians and nurses are interested in assisting at one of the fixed sites, how would they go? What's the best way to go about that?
So there is Volunteer New Hampshire, and Colleen, do you mind putting that in the chat?
Yeah, sure.
So Colleen's going to put that website in the chat. That is how people can go through and volunteer and set up to volunteer at the different sites. We would actively encourage you to do that, and we really appreciate that effort. One thing that I will say is that out of this response, there is not that I am aware of a order at the government level of state licensing that says that if you don't have an active license, that you can vaccinate. Or another way to put this is you need to have an active license in order to actually be a vaccinator. Now, that isn't to say that you can't help out in a variety of other ways with this response in terms of being an ambassador, helping helping handle questions about vaccination or staffing, or even helping in the lines of people coming in to be able to answer their questions as a part of the process. It's truly just that vaccination area, but I just want to bring that up as a point.
It's a great point. We can work with OPLC on speeding that process if on an emergent basis someone wants to relicense for a limited mission. They do allow that, and we'll make sure to get that information to you and to other participants. Let me see. What type of dashboard with the state that does the state offer for on the vaccine front? We see details about the folks who have received the vaccine and any data on acceptance rates.
So excellent points. We need to communicate that out to everyone in terms of what we're doing and how we're doing it. Right now, we're currently in talks about how to do that, and I apologize. We're behind the ball on that, along with communicating with all of you in terms of getting vaccine out. And so please understand that while we want to be completely transparent about how this is going, it's part of it is a bandwidth issue. So we want to make sure that we get that data out and we have people working on that and what those data points are being collected so that we're clear on that. And at the same time, trying to make sure that you guys have the information that you need to sign up and get vaccinated. And we're working that through so that it doesn't become a cluster.
Great. Next question is, are you collecting data on expected effects, otherwise known as side effects of vaccination like fever, local reaction, diarrhea, and if so, how?
Thank you for that question. It's very important. So as a part of this effort, when I say we are collecting data, let me be clear on which we I'm now referring to. So when we're talking about collecting data, we're talking about collecting data through the typical VAERS system, right? So the VAERS system relies on healthcare providers to make a judgment on how severe the reaction is and whether or not it's reportable to VAERS or not. But that is our established mechanism that's been in place for a long time to go about communicating side effects, and that's what we would encourage you to use for that. So at the state level, not capturing that. At the federal level, capturing it through VAERS, as well as there's something called vSafe. And vSafe is CDC's attempt at doing the best that they can to get information in real time from the patient. And so there is a pamphlet that will go out as a part of this for those of you that are getting this as a patient and then giving it to patients. And basically it's a text option, which basically allows CDC to send you a text message that says, hey, how are you doing today? Do you have any side effects? That's done weekly for a time period, or daily for a time period, and then weekly for a time period up until I think 3 to 6 months out or something like that. So that's how they're trying to keep up with the data, reporting it and congregating it at a federal level so that they can be nimble enough to turn around and say, hey, we got to put the brakes on something or another.
Great. There's a couple of questions related to the provider agreements, and just know that we did receive those provider agreements from the Bureau. We will be sending those out to all physicians and PAs, as well as anyone who participated today. We'll make sure that you get that information out today. A specific question: how are behavioral health practitioners seen in the process?
So behavioral health is a very, very important part of our overall health overall. So I mean, the point of this is really, if you're talking about where you fit in terms of the schema of getting vaccinated or not, we're looking at you guys talking about your environment, your work environment, to modify based off of your risk of healthcare provider and go through from there to get vaccinated or not. So I'll give you a prime example. In the ERs that I've worked in, right, we have mental health professionals that come in and are doing risk assessments and making sure that people are staying safe. They're having direct patient exposure. They're in the rooms for a long period of time and everything else. They would absolutely be in that most risk category. We also have others that are doing telehealth and things like that, and going through that and setting that up. And while that might not be their optimal way of doing it, they at least have a way of moving forward with their patients. Again, we're asking for you to stratify based on what your situation looks like.
Terrific, thank you. Next question is, there's a couple who've asked this question. Who will be allowed to administer the phase 1B and other phase vaccines, and does that include MAs?
Excellent question. So let's take the two different categories here. So the first one I'm going to take is the one probably most relevant to you and what you're talking about, right? So when we talk about administering vaccine under the private side of the response, that's under your facility's medical purview. So just like any other procedure or implementation, it would be on you to decide who is able to vaccinate, right? So I've worked with MAs where they had the full setup to be able to vaccinate and go through that. There were criteria in place to make sure that they got annual training on it. It was set up and it was fine. I've worked in other facilities where MAs did not have that capability and were not leveraged in that way, but for other important tasks. So again, at the private level, that's up to them. On the public side of the response, that goes off of, again, our medical direction and making a very similar determination about who can vaccinate and who cannot as a part of our public response. Right now, with what we have for vaccinators, we're going through licensed vaccinators first to fill those needs. If and when we get to a point where we need to expand that pool, then we will be looking at other categories to figure out how we can try and onboard additional medical people to help out our vaccination efforts.
Terrific, thank you. Next question is, will people that have recovered from documented COVID-19 be eligible for the vaccine?
Excellent question. So yes, and the question of really comes down to timing, right? So we don't want someone who is actively infected to get COVID vaccine, right? We want you to finish out your quarantine, finish out your time period there, and then come to get vaccinated. But there's every indication with the research out right now that there's, that us getting infected in the wild, so to speak, right, is not producing a long-term good immuno effect. So with that, we have to then look at vaccinating those people just as much as anyone else. But again, we want to have you finish your quarantine time and go from there. Let me take the follow-up question that normally comes right after that in terms of isolation and things like that. If you are on isolation, we want you to finish out your isolation, please, before then you come to a clinic to get vaccinated.
Thank you. Next question it regards, is there any liability administering the vaccine?
Great question. Dr. Chan, are you around by chance?
Yes, I'm here. I'm not sure the answer to the question around liability. I think partly it depends on the person is talking about individual liability. I mean, I know that there are systems set up in place. Oh, sorry, I'm getting a notice here to start my video. I know that there are systems set up in place nationally for, people that have serious adverse reactions to the vaccine. In the vaccine studies, that was very, very rare, on the order of like 0.5% of people had a serious adverse reaction in the Pfizer study and 1% in the Moderna study, and there was no difference between vaccine populations and study populations, right? So I think the rate of serious adverse events from the vaccine has been very, very low. Regarding your question about, I think it's about individual or your local business or facility liability. I don't know the answer to that, but there are mechanisms set up nationally for people to be compensated for adverse vaccine events. That might be that's a question I know that the AG's office partly has been looking into. There's been the question of can businesses or facilities mandate vaccine that's been one legal question that I know the AG's office in New Hampshire has been looking into, and I haven't seen a firm solid answer on that. But the question about liability protection around the vaccine is probably more of a legal question that I'm not sure that TW or myself or Colleen have the answer to. So sorry for that.
Great. So last question that we'll ask, and then we'll just do a little wrap up. How will a second dose of the vaccine be scheduled?
Thank you. So that's an important part of this process, as you all know. So first thing that I would say is I think we need to, it's a little off topic, but that we need to ensure in our communications that we're talking about having good, effective ability to fight the vaccine at that 95% that Dr. Chan was talking about after our second dose. And after that second dose, it's going to take a week or two to build up. And so when we're talking about how effective it is in the time frame from your first dose to your second dose, we really don't have the data in yet to say how effective it is in that time period. So that's the first thing that I want to say. The second thing that I want to say is that when you are looking at your second dose, it will come to the same place that you got your first dose in terms of allocation. So the way that this looks on the ground for the person receiving the vaccine is that if they utilize the VAM software to sign up and put everything in, and if they put in their cell phone number, they will get a text message reminding them to schedule again to get their second dose of vaccine and how to do that. If they do not use the VAMs and they're using a private software or whatnot, it would be beholden of that process to figure out how to get that reminder recall out and to them. But the vaccine allocation itself will go to the same place that you got vaccinated the first time.
And if I can add to that just quickly, the primary system is VAMS. If somebody's registered in VAMS, as TW mentioned, send a reminder. But there is the vSafe tool that my understanding is also can send a reminder to people that enroll in the CDC's vSafe tool. So we're promoting that. And then at the point of vaccination, people will also be getting a vaccine record card documenting when they got their first dose and when they should be scheduled for their second dose. So some of this is going to be, if for some reason they bypass the systems set up to remind them, some of this may fall back on them to remember when to get the second dose of the vaccine. There is the ideal time frame of after the Pfizer vaccine, I think it's 21 days later to get the second dose, and with the Moderna vaccine, it's 28 days later to get the second dose. So there are some differences in the vaccine. If somebody comes in 2 months later, for example, and hasn't had their second vaccine, they can still get it then. It's recommended to be given as soon as possible after those time frames. And there's not a need to repeat the series, so to speak. So if somebody comes in 30 days or 40 days or 50 or 60 days after their first dose, they can still get the second dose of the vaccine. But we obviously want to try and have a structured process for getting people back in when they should.
Good. Any concluding remarks? We thank Ben and TW and Colleen for your time today. We look forward to this as an ongoing. The last thing, I'll just kind of come back to TW, your early comments. You said that you're working on a guidance this week for the distribution. When do you anticipate that will be coming forward? I don't want to put you directly on the spot because I know these can be squishy sometimes.
Yeah, no, I appreciate it, Jim, because that's the exact question that I know I'd be asking if I was on the other side of the table. So we're doing our best to push that out as quickly as possible. I want to say by Thursday. I think we need to have it out by Thursday, and we're working through the processes to make that happen. So if you do not see guidance on Thursday, I promise you, I guess what I can say is it's for a very good reason. And we're working to try and allow people to work through that as quickly as possible. But we don't want to create a system in which you all go to sign up and the system crashes, or we haven't anticipated some of the technology issues. So we're doing our best to make sure that we work through those areas in the back end. So when you do get the guidance, it's a reliable system.
Terrific. Again, thanks for today, and maybe next week we can go into a little bit of depth or any kind of questions people have about that particular guidance. I know that'd be very much appreciated. We will send everyone, all the partners, the links that were displayed. Plus, we'll send out the agreements that you can use to be a site for distributing the vaccines. And again, thank you for everyone for participating. And again, thank you to Ben and TW and Colleen in particular for your time. We very much appreciate it.
Great. Thank you. And thank you to the New Hampshire Medical Society and New Hampshire Hospital Association and Business and Industry Association for helping to organize this. Appreciate it.
Thank you for all that you do. I truly appreciate you guys.
All right. Same link. Next week, same bat time, same bat station. I just dated myself, didn't I? Bye-bye.